So we'll just kick off without further ado. This is the annual update of the UK Adult Immune Thrombocytopenia Registry, of which the association has been very strong supporters for many years. And I'm delighted that Vickie McDonald is going to give that presentation. Thank you, Vickie.
Lovely. So yes, thank you all very much for coming, and it is great to be here this morning despite our train dramas. So trying to think about what kind of things you might want to hear about for the registry, the types of work we've been doing. I've kind of divided the talk a bit into why we might need a registry, and perhaps present a different angle of maybe some of the data. Mark was talking about randomised controlled trials, but perhaps what other bits of information we can always use in the clinical setting to help perhaps give us some of the answers that Drew was alluding to this morning, about kind of optimal timings of treatments, etc. And then a bit of a snapshot of some of the data and projects we've done over the last 12 months, trying not to repeat what we talked about last year if you did join last year. So this is just a picture of the Royal London and a snapshot of what our website looks like for the registry. So within this talk, I'm going to talk about the importance of registries, the structure and recruitment of the UK Adult ITP Registry, some projects from the Adult Registry, some projects from the Pregnancy Registry, and then just quickly allude to the Secondary Registry, which Dr. Hill is co-leading on with. So I think increasingly we see in the media and in other settings, and certainly in healthcare settings for sure, terms like real-world data and real-world evidence. And thinking about why that is important and what these bits of information might tell us. When we are looking at treatments and do randomised controlled trials for drugs, for example, rituximab, where you have 2 schedules, and those trials have very specific inclusion criteria. So there'll be an age criteria, there'll be, you have to have a certain platelet count for ITP, and so patients are often quite homogeneous within those trials. Now that's great for getting information about then directly comparing what happens with 2 treatments, but in reality many patients don't fit a specific box, and so it is really important to be able to then understand, well, if we think that that is right, then when we look at the broader population, does that really translate? Are we still doing the right thing by patients? Are we still using treatments the way we should use them? And so these terms, real-world data and real-world evidence, have creeped in. So real-world data relates to patient health status or delivery of healthcare, and it's routinely collected from a variety of different sources. And then real-world evidence is then the evidence regarding the usage of how we've done it, potential risks and benefits of a particular medicinal product or medicinal device, etc. And it's derived then from the analysis of the data. So the data is what's going in, and the evidence is what we've produced having looked at that data. And they are both playing an important, increasing role in healthcare decisions as technology becomes much more of a thing, both in the healthcare setting, but also at home. We're wearing Apple Watches and we've got different devices that can measure things, and patient outcome measures that you can put in yourself from home. We've got an increasing amount of data that we could potentially start to use and look at. So there are lots of different sources, and highlighting here in red the one that I'm going to be talking about is a kind of registry. But you've got electronic healthcare records, we've got administrative data in countries that don't have a universally kind of free at the point of care healthcare system that use insurance, and there's claims data, there's patient generated things, there's chart reviews, there's a whole vast array. But within that there are patient registries, and those are kind of slightly more organised systems that are there to try and collect semi-uniform data, I would say, actually, clinical and otherwise, to look at certain outcomes for certain populations. So population could be where a group of people live, so specific socioeconomic circumstances, or it could be a particular medical condition like ITP. And we have lots of different registries already in the UK and already within haematology, and ITP is one of them, but we have several others that all serve subtly different purposes. So why is a registry important for ITP? And I think Dr. Prove and Professor Newland had the foresight to see this coming. ITP is a rare disease, and so unless you have every patient managed in a single centre, and that is never practical and going to happen, it can be very difficult then to pull in sufficient numbers of patients to be able to understand outcomes and how things are progressing. Increasingly, we have got a greater number of high-cost drugs. Historically, for ITP, many years ago when I first started, we had steroids, we had a bit of rituximab, which was thought to be expensive at that point in time, but we now have a whole array of current relatively high-cost drugs, like the thrombopoietin receptor agonists, but we're going to have some other ones coming. We've got fostamatinib that's just come through, and we're going to have some other more targeted therapies coming. And that is important around healthcare resource, both access for patients, so that we make sure that patients get the right access at the right time, and utilisation. There are times where a clinical trial is very difficult. In the current era of TPO-RAs, for example, direct comparisons of different immunosuppressive therapies could be very challenging, because most of the time now we are going to TPO-RAs early, and to get enough patients that might fit a specific criteria to randomise and then have enough patients in there to make any conclusions could be quite difficult. Whereas if with something like a registry that's been going for a very long time, we can pull some of that historical and current data and potentially have enough information to give us what we need that might inform further studies. I think it is important in the current climate that has changed in the last few years, understanding implications for access to treatment and being able to try and provide evidence to, for example, NHS England or NICE, and say, well, actually, this trial says this, but if you look at the registry data, we can see that, compared to that is this. And certainly we have done a piece of work for the NICE technology appraisal recently for fostamatinib, which helped reset their decision, which was initially no and then became yes. There are questions around implications for resource requirement for longer term care for patients. Recently, the previous epidemiologist that worked with Drew and Adrian looked at the revised frequency of ITP in the UK using kind of more central NHS data, but then went on to look at, well, what are the implications for that if we have how many patients don't need treatment in the registry, how many then need first line treatment, how many need second line treatment, and we can start to say, well, actually, what might be the resource implications when we're thinking about where treatments come in. Now, many of these are quite complicated, and it takes a bit of time to get the various amounts of information in to be able to do that. But those are the types of reasons why in something like ITP, this is quite crucial to be quite a powerful tool for us as a community to then optimise care for patients. And the final one, which I think will link to what John Semple's going to talk about pathophysiology, is we can start to maybe, if we've got enough patients, be able to pull out groups of patients, for example, that need 7 or 8 lines of treatment to get their ITP under control. Versus there are some people in the registry who have had no treatment, who present with ITP, but the platelet count's always been above 50. They've never had any problems. Can we start to say, well, what's the difference? Is there anything that this information can give us about how they present, about background features, and ultimately about genetics and biological studies? So there's lots of opportunities when we think about a registry of what this can provide to us as a community. So the primary ITP registry was set up by Drew and Adrian in 2007. We then added pregnancy ITP, and that's co-led by Dr. Robinson at Guy's and St Thomas's in 2018. And secondary ITP is underway. The data sets have been written. Dr. Hill is helping us with that. And we will ultimately be rolling that out later on this year. And I think that is going to add quite a few more patients to the group, because primary ITP is a relatively small number. So, how does the registry work? So, in order to be recruited into the registry presently, your hospital that is managing your ITP needs to be part of the registry. It is a study with ethical approval, a protocol, and that is to protect patients, the data, sites, and the registry itself. The team will ask you, would you like to be part of it? They will ask you whether you want to be part of the primary registry, the bulk of which is data. There is a separate consent if you want to provide a sample for DNA. And then if you're a lady of childbearing age who wants to have a baby and becomes pregnant, then there is a separate consent for pregnancy. And we felt that we wouldn't assume that ladies who fell pregnant would necessarily automatically want us to collect that extra data without specifically asking. So that's why there's a second consent. For secondary ITP, it'll just be the same as the primary ITP one. And then our 2 data managers keep an eye on the data, keep an eye on the sites, and they've developed a kind of interactive dashboard actually where we can see then where recruitment hotspots are, we can see where there might be challenges. We've had just over 5,000 patients now, which is a really good number for primary ITP, and it's nice that there's quite a lot of long-term follow-up for some of the patients. And we have a flavour then of kind of biggest recruiting sites, maybe sites where there's been challenges. I think COVID has given as a challenge for a couple of reasons. We did actually change consent to remote consent for this, but there was a bit of a lag time. The second is that during COVID, all trusts were asked to focus on COVID trials to understand outcomes and vaccines, etc. And of course, then there's a reset programme to get back up to speed. So there is a little bit of a lag time kind of catching up from that, but I think we're doing pretty well. And actually, our recruitment numbers are pretty good for the last few years. So we're very lucky. And I think the sites and teams are great at being engaged, and we thank the patients for that too. So the database is a remote access database. We use a system called REDCap, which quite a lot of registries do. And within that, we can decide what we want to collect and how we want to collect it and how we want to design it. So once a patient has consented to join the registry, then the site fills in, we give them a form, and the patient gets an identification code, and that is what's used from there on in. So there's no identifiable information within this database. It's just done by an identification number. Now, we have got a list of who's been recruited, so we don't get double recruits if patient move hospitals, but that is kept completely separately. So there's no way of identifying people through this. And then once you're in, you then decide which database you're going to be entered, or you don't. The site will decide which database you're going to be entered in, whether it's primary ITP, whether it's pregnancy, or whether it's secondary. And we keep those separate to avoid muddying the waters, and it's just a bit easier to handle the data. Once that's gone in, there's a set of pre-filled forms. And what's really nice about REDCap is there's also a traffic light system. So we can gently remind sites that there's still a few little red bits along the way of bits that may need to go in. Now, some of it may not be relevant to individual patients, but quite a bit of it is. It's fairly generic. And we kind of talk the sites through as they enter the data, because it may not be your consultant that enters this data. Most studies do it with like a trial coordinator or a study coordinator or a trial practitioner. So they may not be clinicians. So the information has to be simple enough that they can follow that without too many queries and without them having to go back and add in gaps and things. And we now have an electronic data query tool, so if we're stuck about something or we're trying to do a study and there's a couple of bits that we need latest follow-up on, we can just send that out automatically to them and they can send that back. So we're not alone in having registries in ITP, probably one of the earlier ones, but we aren't alone. So there are lots of different registries in ITP, both closer within Europe and then more broadly internationally. And these are the main ones that I can find. I'm happy to stand corrected if anyone's got other. The European ones, there is a European research collaborative of which Drew is part, of which Mark is part. And they're kind of key opinion leaders across Europe. And there is a piece of work around trying to standardise some of what we collect, or at least understand how they may be applicable, because the more you can have, the better, really. And there will be differences in the way, for example, steroid doses are used in different countries. Then you start to have an opportunity to widen that net of what you can learn. So there's a variety. Now, some of them are population-based, so the Nordic ones, and then some of them are, as we've talked about, clinical registries, where we're asking quite targeted questions. And not that long ago, the ERSI group did publish what registries are around for ITP across Europe, of which the ITA Adult and Children's ITP is registered. And within the registries, actually, we're pretty sizable, I think, probably partly because of the longevity, but also about how good our teams are engaging with this process. And I think also we're really lucky that the Patient Support Association promotes that too, because I think if we can all come at it from all angles, we'll get the best numbers and outcome. And the same, the Pregnancy Registry is listed too. So when we're looking at the registry and trying to then say, right, what do we do? So we know it's running, we've got the data coming in, things are ticking over. It's then up to us strategically to think about what is it that's going to be most helpful for patients? Because ultimately, this is about optimising care, treatments, access to treatments and outcomes. So the types of projects, certainly over the last 5 years or so, that we've been looking at are ones where we can say, right, there are some questions here, what should we do? One of them was comparing the standard and low dose rituximab, so we've talked about that before. Looking again just at the standard epidemiology, how common is ITP, what are the standard clinical features? Splenectomy is always a hot topic of discussion. We don't do them very often in the UK, but we keep looking and saying, well, how often are we doing it? And it's single figure percentages of treatments each year. So it isn't very common, but also looking about where we might position that. And I think you will have seen that data before as well. More recently, we have been looking at the TPO-RAs in older patients. And because, again, sometimes in older ITP, as Drew alluded to in his talk, we hear, oh, it's much worse. Drew showed you actually there can be quite a bit of bleeding as you get older in ITP. do the TPOs work? Do they work as effectively? Can we get a flavour of are there any issues? And then we've done some work around COVID-19 and treatment changes during COVID-19. We've got a longer term study with Quentin Hill looking at some of the genetic mutations in one of the genes that binds to rituximab and IVIG and can determine responses. So that's work underway. And we're also doing a piece of work around vaccination and ITP, but that takes a little bit longer to understand and get the data out. So that won't be ready just yet. So I thought it might be useful then to just give you a flavour of some of the data from more recent projects. So this is the older patients with primary ITP receiving thrombopoietin receptor agonists. So we took all patients over the age of 60 who had received a thrombopoietin receptor agonist in the registry, and we looked at their epidemiology, we looked at the response by platelet count and by bleeding. We don't collect quality of life data in the registry, so we're not able to do that at the moment. And then any significant events and comorbidities that might influence how patients were managed. So this is the demographics, so the kind of age and then the time to getting the treatment. So the first column is all the patients together, patients that received eltrombopag and patients that received romiplostim as their first thrombopoietin receptor agonist. And we can see that it's slightly higher numbers of men than women, and we would anticipate that. ITP gets more common in men than women when we're over the age of 60. And then the average average age at first thrombopoietin receptor was about early 70s, 72.9 for eltrombopag, 73.1 for romiplostim, so not different. And the time to diagnosis to first TPORA overall was about 1.7 years, and roughly the same across the two groups. Some patients getting it a bit early, and that's from more recent patients entered when we changed the way we managed ITP with the COVID-19 pandemic. And the average, we use median, there's lots of different ways of doing the average, but the median average treatment lines before the thrombopoietin receptor agonist was 3 for all groups, between 2 and 4. And again, we would expect that because there are some patients who have been managed with TPORAs a long time, and historically we had to use steroids and then an immunosuppressant and then access TPORAs. Quite a few patients were on other medicines at the time of the TPORA, and the biggest group was steroids, which I guess doesn't really surprise us, although we are trying to cut back on our steroid use, as Quentin was talking about earlier. Few had IVIG around that time, and then there were some patients who were also on immunosuppressive medicines like rituximab or mycophenolate or azathioprine at the same time. This is the platelet count responses. So this is the average here in the little box for each one. And red is romiplostim and blue is eltrombopag. This is baseline and up to 2 weeks before. The reason we do that is that because this is a real world data study, we can't say patients have to come on this day for this and this day for that. We take the data and then we will interpret it and say, right, well, they were diagnosed at this time. We've got a platelet count within a 3-day window. It's not like the clinical trials where we specify when you have to turn up, because otherwise it becomes unworkable. So baseline and up to 2 weeks before them starting, and you can see then that the platelet count goes up, pretty quickly actually, 2 to 4 weeks after, 3 to 4 months, 6 to 7. So we get a good response, no different between the others. There's quite a range. Some patients are going a little bit high. But overall, we're getting where we would expect to be. And this is similar to the data that we see in patients who are under the age of 60. So this is great, in the real world setting where it might be outside of those very tightly controlled clinical trials, we're still seeing the same response rates in this older patient group. And then looking at the bleeding events, so we looked at platelet count to measure response, but as Drew said, that's not the only thing that we can look at. So we look at the bleeding as well, and we can see, so blue is before this patient started a thrombopoietin receptor agonist, and then orangey colour is afterwards. We can see actually a lot of patients have bleeding, particularly skin bleeding. And that will be in part the ITP and the low platelet count, but in part, as Quentin talked about this morning, the kind of skin-related side effects of steroids as well. So yeah, 60% have some kind of skin bleed, the dots in the skin, the bruises. About 40% mucosal bleed, so that could be nose, it could be gums, and then about 25% organ bleed. And then, so that could be brain, liver, spleen, elsewhere, and then other bleeds, the kind of anywhere else that isn't listed in those key groups. So we can see that there is certainly a reduction, but patients over the age of 60 are still having a reasonable amount, particularly of skin bleeding, despite getting their platelet count up and despite quite a good response. Now, we do know that all people as we get older can also get more easy bruising on the skin. So difficult to know whether that is ITP specifically related or other, but most bleeding gets better, although we still can see quite a lot of bruising despite good counts. One of the things that I think is important for our older patient group who are going on to the thrombopoietin receptor agonists is understanding thrombosis risk factors. For those patients where thrombopoietin receptor agonists have been discussed, there has always been a background discussion about the potential for blood clots and thrombosis. Now, we recognise with more sophisticated models of analysis that most of the thrombosis risk appears to be if the patient has other inherent background risk for thrombosis. Things might be a bit worse. And so as we get older, we do have more background risks for thrombosis, in particular arterial, coronary events and strokes. For example, hyperlipidemia, hypertension, and all those cardiovascular risk factors. So one of the things for us clinically important to understand is, yes, patients responding as well, that's brilliant, but does it come at a cost for those patients? So we went and looked at the arterial and venous thrombosis for our patient group and looked at the number of risk factors of those thrombosis and then the percentage of patients who had a thrombosis. So only 34% of patients don't have any. And we can see that then the vast majority have some. But despite that, we don't see any problems, major problems with thrombosis. So this is thrombosis at any time point, and this is thrombosis before the first TPO-RA and afterwards. So we're not seeing an increased risk of thrombosis. Okay? So I think we can be quite satisfied. Adrian has asked me to crack on, so I shall crack on. So to conclude, we've got comparable response rates to the TPO-RAs in patients over 60 compared to under 60 from the literature based on platelet count response. It's associated with a reduction in bleeding risk, which is fantastic, and it's not coming at a cost of increased thrombosis risk in that patient group, despite the fact there are quite a considerable number of thromboses. So I think that's quite positive and gives us a flavour. So I'm going to stop there because Adrian wants to move on to the next talk. Hopefully manage to cover some of the helpful bits around primary ITP registry, secondary ITP pregnancy. If there's any questions for me, either come and speak to me or any of the Royal London Immunohaematology team, Dr. Praven, Dr. Chen, Louise Taylor, nursing-wise, and obviously some bits and bobs on our website. But please, thank you very much for engaging with it. Thank you very much for listening.